The entrance trial is a phase 3 trial that was designed to ask the question if carfilzomib lenalidomide dexamethasone combination is better than the current standard of care, that is bortezomib lenalidomide and dexamethasone, for newly diagnosed myeloma. The trial was designed just to ask that question in patients who either are not eligible to go to a stem cell transplant or were planning on deferring their stem cell transplant to the time of their first disease progression. And we specifically looked at patients who did not have high risk features to complement an ongoing phase 3 trial that was specifically looking at high risk patients in the same setting. So the study was designed to ask two different questions, such as a randomized trial. The first question to be addressed was the comparison between the two different induction therapies in terms of their progression-free survival. The study also had a second co-primary endpoint that is to look at the impact of duration of lenalidomide maintenance given after injection therapy. So patients who completed the injection therapy were randomized a second time to receive lenalidomide maintenance either for 2 years or until disease progression continuously. The focus of the presentation at ASCO, which represents the first analysis or the analysis for the first endpoint, which is the progression-free survival following the two different induction therapies. The trial included only patients with newly diagnosed multiple myeloma who had received no more than one cycle of therapy but did not have any proteasome inhibitors or immunomodulatory drugs as part of that one cycle. And also patients who did not have any high risk features like translocation 1416 or 1420 or deletion 17p or a LDH that is significantly elevated, more than 2 times the upper limit of normal, or patients with plasma cell leukemia. So essentially, we are looking at a group of patients with standard or intermediate risk multiple myeloma. The study randomized patients to either getting bortezomib, lenalidomide, dexamethasone as 12 3-week cycles or carfilzomib, lenalidomide, dexamethasone as 9 4-week cycles. The dose of lenalidomide was same in both arms. In the 3-week cycle in VRD, it was given for 14 days out of 21 days. In the KRD, it was given for 21 days out of 28 days. The bortezomib was given at 1.3 milligram per meter square twice weekly for 2 weeks on, 1 week off each cycle, whereas carfilzomib was given at 36 milligram per meter square twice a week for 3 weeks on, 1 week off after the initial 2 doses of 20 milligram per meter square. Dexamethasone was standard dose as well. The second interim analysis, when we met 75% of the anticipated progression events, demonstrated that there was no difference in the progression-free survival between carfilzomib, lenalidomide, dexamethasone, and bortezomib, lenalidomide, dexamethasone, two important proteasome inhibitor IMiD triplets that we use for initial therapy of multiple myeloma. With both the regimens, the median progression-free survival was approximately 34 months from the time of induction therapy. We did notice that there was a deeper, higher rate of deeper responses like very good partial response in the carfilzomib, lenalidomide, dexamethasone, even though the overall response rate was identical for both the arms. However, this improved depth of response did not translate to an improvement in the progression-free survival in this phase 3 trial, which we think is likely related to the more severe toxicities that we observed in the carfilzomib, lenalidomide, dexamethasone arm. Overall, about 43% of the patients in the bortezomib arm and about 61% of the patients in the carfilzomib arm completed the intended number of cycles of induction therapy. The majority of the patients who went off study before completing the injection therapy did so because of adverse events or patient refusal to continue with the injection therapy. When you look at the overall toxicity rates, while the overall rates of all toxicity seemed similar between the two arms, when you look at grade 3 to 5 non-hematological toxicity, this was significantly more in the carfilzomib arm. More importantly, when we look at the cardiac, pulmonary, and renal toxicity, this appeared to be significantly more in the carfilzomib arm. In contrast, we saw significantly more peripheral neuropathy in the bortezomib, lenalidomide, dexamethasone arm. At the time of the most recent follow-up, as of January of 2020, the overall survival appears to be identical, and the 3-year estimate of overall survival is approximately 85% in both the arms in the clinical trial. The clinical trial is continuing to follow patients to look at the second co-primary endpoint, which is the overall survival based on the two different maintenance strategies for these patients. So patients have all patients have already been randomized who completed the injection therapy. Approximately 530 patients have been randomized to either indefinite lenalidomide or 2 years of lenalidomide maintenance. They will continue on therapy and will continue to be followed for overall survival events. We hope that we will have results of that second randomization in the next couple of years. So this phase 3 trial clearly shows that the combination of a proteasome inhibitor and immunomodulatory drug and dexamethasone is effective for initial therapy. The results that we saw in the bortezomib, lenalidomide, dexamethasone arm is consistent with what has been observed in other phase 3 trials. The trial does not show an advantage of using carfilzomib, lenalidomide, dexamethasone in these patients for initial therapy. So bortezomib, lenalidomide, dexamethasone still continues to be the standard of care for initial treatment of multiple myeloma who don't have high-risk features and in whom an autologous stem cell transplantation is not anticipated.